All right, thanks very much. So I was asked to speak about the use of TNF alpha inhibitors for hidradenitis suppurativa. And, okay, I can't do that. Great, thanks. In a room with people who have a lot of experience with this disease and who have opinions about the use of these agents, I'm sure there'll be much conversation about some of the things that we'll talk about. I think we'll go over data, but we'll also go over some pearls and some clinical sort of real world scenarios that I find come up from time to time. So it'll be really interesting to hear what the room thinks at some point later on in the discussion. So our objectives will be to review available evidence supporting the use of TNF alpha inhibitors for treatment of HS, discuss advanced treatment pearls relevant to the use of anti-TNF alpha therapy in HS, and include anti-TNF alpha therapy as part of an algorithmic approach to HS treatment selection based on clinical severity, drug efficacy, and adverse effects. So as we all well know, HS is a disease that's due to a combination of various environmental factors in susceptible patients, and I won't belabor all of this, but suffice to say it's quite a complex and multifactorial process that certainly includes a hefty role for host defenses and autoinflammation. So we see, among other things, increased production of oxygen-free radicals, enhanced expression of toll-like receptors and pro-inflammatory cytokines, increased TNF alpha production, IL-23, Th17, and IL-1 beta. So, of course, there's a reason behind the clinical use of drugs that target these different pathways because of the basic science work that's shown that these pathways are important in the disease. So we also very clearly in our clinics see patients that exhibit an autoinflammatory type disease spectrum, and so we can have an appreciation for why these drugs might have a role. So this was a patient with hidradenitis and also pyoderma gangrenosum, and we see this with some regularity. This was a patient, with ankylosing spondylitis, hidradenitis, severe acne, pyoderma gangrenosum, really a PEPASH type scenario there with these more pyoderma gangrenosum-like lesions in addition to the hidradenitis and the joint pain. And then I feel like this is a fifth of the patients that I see now, hidradenitis as well as inflammatory bowel disease, and these patients have their own unique set of issues as far as picking drugs to try to control both processes. So when we're talking about treatment, as has been alluded to, we want to use the disease severity and roughly speaking the Hurley staging, mild, moderate, severe, to help select an appropriate therapy. We want to choose among therapies which are evidence-based and which attempt to address the pathogenic features we think are important for the disease. And of course, no therapy is universally effective, so we're going to have to do a little bit of trial and error, and we're going to have to utilize combination therapy in many cases in order to get the improvement that we're looking for. So everyone in the room will be familiar with Hurley staging. Certainly, Hurley stage 1 is most common, but in our referral practices, we see a fair subset of patients with Hurley stage 2 and 3 disease, which certainly is quite a bit more challenging. So I am a big believer, as has been alluded to before, I'm a big believer in treating any patient who's coming to medical attention with hidradenitis. I want to treat them with some kind of chronic preventative therapy, medical therapy. I think that's really important, but not all of those patients necessarily need a TNF inhibitor. In my mind, the appropriate candidate for a TNF inhibitor is somebody who has moderate or severe HS, Hurley 2 or 3, and has either failed combination antibiotics, such as clindamycin, rifampin, or other therapies, non-antibiotic therapies, or has disease which is severe or inflammatory enough to justify biologic therapy from the start. So certainly there are patients you take one look at and you know 3 months of doxycycline is not going to get you anywhere. Perhaps you should go straight to a biologic, and it's this kind of patient here with these acute, suppurative, erosive, really inflammatory disease, and people who are maybe not this impressive, but you can clearly tell would benefit most from a TNF inhibitor. So I want to briefly review the data. I think most of you will be familiar with all of these data, but since there aren't that many studies, it's possible to go through them just to remind you of what they actually say. So there have been many case series and small studies. There was this 2013 systematic review that included 65 studies, only 4 of them RCTs, with 459 patients. And of course, these studies are all over the map, in terms of the dosing and in terms of the response criteria, but basically the outcome of the study was to say that infliximab and adalimumab were felt to show the most promise, especially when administered in higher doses, and I think that's really a key component. With respect to infliximab, so it's hard to believe there's really only been this one prospective study, 38 patients with moderate to severe HS. And I put an asterisk by all of by what the response criteria actually were for the study. Not so much that we have to go through it, in detail, but just to indicate that these studies have different response criteria, so you have to keep that in mind trying to compare study to study. But in this particular one, 27% versus 5% of those in placebo achieved a greater than 50% improvement as they had defined it at week 8, so perhaps a little bit early in the treatment course. This was not statistically significant. When they included moderate or significant improvement, that's greater than 25% improvement, that occurred in 87% of the treated group versus 11% of placebo. So some reason for some optimism with that agent. And then all the secondary endpoints that they looked at improved significantly. This adalimumab study that was from 2012, this was a phase 2 randomized placebo-controlled trial, 154 patients with moderate to severe HS, and again, different response criteria. There's HS-PGA score of clear, minimal, or mild disease. And this was achieved in 17% of those with weekly dosing, 9.6 every other week, and 4% placebo. And really, I think the take-home from this was, and this is really like the only real dose finding that's been done in TNF inhibitors. So the take-home point was really that every other week dosing just isn't sufficient. And of course, that led into the studies that we're well acquainted with, the Pioneer 1 and 2 studies, which included over 600 patients. And again, a new response criteria, the hidradenitis suppurativa clinical response score, 50% reduction from baseline. It was considered, in total abscess and inflammatory nodule count, was considered the primary endpoint, and response at 12 weeks was about half of patients compared to about a quarter of patients on placebo. So here there's a little bit higher placebo response rate, but certainly a difference there that's being shown. Importantly, this is not a cure necessarily, and many patients are able to continue to get mileage out of this drug moving forward month after month, but a good percentage of them also don't maintain response over time, and so that's an important thing in thinking about long-term treatment options for patients. So of course, adalimumab is now FDA approved for HS based on these results. So there has been some attempt to try to tease apart, which of these drugs may be better. This is not a particularly definitive attempt to do that. This was 2 retrospective cohorts of 10 patients. You notice right away that the dosing's a little bit insufficient. So this was actually infliximab only at 0, 2, and 6 weeks, and then adalimumab every 40 milligrams every other week. Both groups improved. The Sartorius score decreased by more in the infliximab group. But those dosing issues really are hugely problematic, and we need true comparative studies that use the same validated response measures, the same the optimal dosing regimens in order to really do any kind of true comparative effectiveness research with these drugs. So this is me talking now in terms of dosing issues and giving you my thoughts about what I tend to find to be the most effective. So with infliximab, I think one potential advantage is the weight-based dosing, and I find this to be a potential asset in some patients. I typically will start with the standard dosing of 5 milligrams per kilogram, 0, 2, in 6 weeks, and then every 8 weeks after that. So the standard dosing after the loading dose. But frequently, patients need up titration. So I find that I'm often getting up to 7.5 milligrams per kilogram every 6 to 8 weeks. But you, of course, can go up as high as 10 milligrams per kilogram every 4 weeks. And when you're thinking about a patient, which patient maybe would need this kind of dose up titration, I find that it's the patient who seems to respond initially, and then maybe after a few months, they're telling you, maybe right when they start to go to the every 8-week dosing, that they're flaring week 7, and so perhaps that's a patient that maybe we want to move the dosing to every 6 weeks or increase the dose. And I find that having that leeway is helpful in order to augment the benefit that we're seeing. In terms of adalimumab, certainly there's a need for higher dosing, at least double that for psoriasis patients. Perhaps this is related to the obesity issue. And just to remind everyone that you have this loading dose, 160 milligrams at week 0, 80 at week 2, and then 40 weekly beginning at week 4. So quite a bit higher dose than what dermatologists at least were used to prescribing prior to the most recent studies. Let's talk briefly about other TNF inhibitors. So etanercept There were 2 small prospective studies versus placebo that failed to demonstrate significant improvement, so this is really not recommended based on current evidence. And then there are 2 other anti-TNF drugs, golimumab or Simponi, and certolizumab or Cimzia. So golimumab has 2 case reports. One was positive, one was negative. It was 1 patient each. Really, you can't say anything about that. And then certolizumab or Cimzia, there are no reports, but anecdotally, maybe these drugs might have benefits. So when would you be in a situation like this if a patient, let's say, has inflammatory bowel disease and this is a drug that they're being cycled onto, and they also have hidradenitis, you might see some benefit there. It wouldn't be necessarily our drug of choice, but it may have some potential. Okay, so let's talk about some potential issues with TNF inhibitors and what I consider to be some tips and pearls. So of course the infection risk, hepatitis B, tuberculosis. I would remind everyone it's not necessarily recommended in the package insert, but I always like to screen for HIV. Remember that the population that in the US that's the most likely to have HIV and not know about it is young patients, and especially young patients who come from groups that are underserved. So if we're talking about African American women, other groups that we might be taking care of in our clinics, this is precisely the group of patients that may not know about HIV infection. It's not a contraindication to using a TNF inhibitor, but we certainly want to treat it and have it controlled if we're going to use an anti-TNF. As in other diseases, if one TNF inhibitor fails, another might work. We want to also be thinking about anti-drug antibody formation. I want to take a couple minutes to talk about that. We want to utilize combination therapies for added efficacy. In complicated patients, we need to work with our colleagues from other specialties to address drug choice and dosing issues. And then there's always the question that comes up, when do we stop therapy or when do we back off treatment? And that's a question that sometimes is hard to answer when we're doing well. So anti-drug antibodies. So this is an immune response that's stimulated by the presence of foreign antibodies, in this case infliximab or adalimumab. And this can be responsible for waning efficacy. So you want to consider this maybe not the patient who's flaring in week 7, but the patient who is doing well and now the TNF inhibitor doesn't seem to be doing anything and they're flaring. I like to think about anti-drug antibodies in this situation. And there are a couple of things that are worth knowing about that. First of all, it's at least somewhat common to see this phenomenon occur. It's also more likely to occur when treatment is interrupted. So if patients are having issues with adherence or issues with co-pays or getting in to see you and they're missing infusions or they're missing doses, then this is precisely the scenario where you tend to see anti-drug antibodies. And then lastly, co-administration of immunosuppressants, methotrexate or azathioprine, leads to less anti-drug antibody formation and higher drug levels. So we can use this to our advantage in some cases. And I think here the issue really is that, if these are the best drugs that we have for really severe hidradenitis from a medical perspective, we want to get the most mileage we can possibly get out of them. And so we want to be keeping these strategies in mind. You want to attend to the adherence issues and dosing frequency to minimize the risk of antibody formation. When you have a higher trough level of the drug, if you have more drug in your system at all times, you're less likely to form these antibodies. And so perhaps another reason to err on the side of higher dosing, at least with infliximab where you have that option. You want to suspect antibody formation when, as I mentioned before, the drug seems to stop working. You can test for these. You'll get, when you test for an anti-infliximab or anti-adalimumab antibody, you will get back a report of the titer of the antibody as well as the drug level. And you'll see the titer be high and the drug level be negligible, and that'll be your answer. When that has happened to me, I have just added 7.5 milligrams per week of methotrexate to counteract the anti-drug antibody formation. Our colleagues in GI and rheumatology routinely will put people on methotrexate or azathioprine when they're starting an anti-TNF inhibitor. And that's partly, I think, to treat the disease, but partly to address this particular issue. We don't know whether, from a data perspective, whether we should be doing this in all of our patients from the get-go, but there are data to support that if it happens and then you add a low dose of methotrexate, you can counteract the antibody issue, and I've done this on several occasions in my clinic with great success and gotten improved mileage out of the drug. So this was a patient that I showed the image of earlier. He was a complicated guy, clearly quite severe. Of course, it didn't help that he had a positive quantiferin gold, and I had to double my rifampin Clinda, use it as a treatment for latent TB as well. Then I put him on infliximab. He got better, but then all of a sudden the response waned. He had antichimeric antibodies that were positive. I added methotrexate, and then I got much more useful mileage out of that drug, and this is after I sort of cut off that little remaining scar there, and going from what he was before to that's quite a good result. And this was many months after we detected the antibodies and were able to get more useful mileage out of the drug. Same thing in this situation. This patient also developed antichimeric antibodies. We added low-dose methotrexate, and she got continued mileage out of the drug. Okay, so combination therapies. Improvement on a biologic doesn't necessarily mean cure. So I think every patient gets better. That's been my experience, but it may not be as much better as we would like. So are we going to get 80% of the way there with our anti-TNF, and then maybe another 15%, 20% with the other drugs that we can use? So things like some of the antibiotics that have been mentioned, spironolactone, some of these other drugs that we can avail ourselves of. This was a patient who had long-standing severe HS. She'd had something like 14 or 15 surgeries before I met her. She had severe infusion reactions on infliximab, couldn't tolerate it. We put her on adalimumab. She got a lot better, but still had active disease, which, if I can figure out the pointer, you can see over here. And so then we also added spironolactone and doxycycline. She had improved control. And so we want to be thinking about our topicals, our interlesional Kinalog, our surgical modalities, smoking cessation, all of the other things that we can be using to augment our primary therapy. It may be that the anti-TNF is towing most of the load, but there are other things that can help us out. So combination therapy is beneficial. Same thing in this patient who was doing well on adalimumab, but we added as well spironolactone, and then she was able to quit smoking and has had quite a good result. All right, so we also want to work with colleagues to manage complex patients. We have to consider other disease states, comorbidities, and drug-drug interactions. And as the skin expert, we're in the position of educating. And as in my other job during the week is I do a lot of inpatient consults, so I'm quite used to this phenomenon of, we need to understand that the primary medical team doesn't always, quote unquote, know better. And so we have to advocate for our patients and be part of the conversation. In these scenarios that come up with patients who have severe hidradenitis as well as Crohn's disease, let's say, so if they're not tolerating a TNF inhibitor or it's not effective for their Crohn's, what do they do next? So is it another TNF inhibitor? Is it ustekinumab? I can't put them on anakinra for hidradenitis if they're on another biologic for their Crohn's. Do I add antibiotics? Do they do surgery? And so this is a real conundrum. I want to just briefly mention this drug vedolizumab, which if you co-manage patients with GI, you've seen this drug by now, Entyvio. It works reasonably well for Crohn's, but it has negligible efficacy for IBD-associated cutaneous disease because its mechanism of action is really localized to the gut. So we've had patients with Crohn's plus pyoderma gangrenosum, Crohn's plus hidradenitis, Crohn's plus other neutrophilic dermatoses, other cutaneous issues related to their inflammatory bowel disease, have those issues flare significantly when they've been switched to this drug. So it's our role to educate the provider, the GI doc, that, hey, as we're making this decision, perhaps ustekinumab, if they really can't be on a TNF inhibitor, we know that ustekinumab is FDA approved for Crohn's. It's also something that there's some data for hidradenitis, or perhaps another anti-TNF agent. So this is a time when we need to have conversation with our colleagues. Or how about this patient? She was a patient who had end-stage renal disease. She was actually supposed to be listed for transplant. They weren't listing her because of her skin infection that she had, her hidradenitis. She had well-controlled HIV, severe HS, and also these pyoderma gangrenosum type lesions as well. So this is really about care coordination. I want to educate the transplant team, hey, this is not an infection. This should not exclude her from the transplant list. I have to work with infectious disease, make sure her HIV is controlled, make sure they're comfortable with what I'm doing. And we want to make sensible drug choices. Yeah, I don't want an overly immunosuppressor if she's going to have a TNF inhibitor and then later she's going to be on Cellcept and tacrolimus and prednisone for her renal transplant. That might be an issue. But if I have her on clindamycin and rifampin, I'll tell you the rifampin is a much bigger issue as far as getting adequate levels of tacrolimus and so on with all the drug-drug interactions. So actually the team is comfortable using a TNF inhibitor in this setting. And there she is. Actually, she just started adalimumab a short time ago, and that lesion, that sort of pyoderma gangrenosum-like lesion, is already doing quite a lot better. So I think the last question I wanted to touch on was de-escalating therapy. So if we're thinking of HS as a systemic inflammatory disease, which I think we can agree we probably should be, we should probably think of it as being similar to rheumatoid arthritis or inflammatory bowel disease in that respect. And so, I use the analogy. Patients will say, how long do I need to keep taking this if it's working? And I use the analogy of, if you have bad Crohn's disease and we finally get you under control, We're not saying, congratulations, your Crohn's disease is under control. You can stop the whatever. And I think of HS as being the same way. If we get this guy better medically on infliximab or adalimumab or whatever we're using, I'm not sure that means that it's cured. So I tend to, if we're managing it successfully and they're tolerating the drug, especially for these more severe cases, I think even it's not defined, there's no data for it, but I tend to keep going with the drug. Okay, so I'll probably breeze through this because I imagine we're short on time, but I think in general, we want to find places for multimodal therapy, and certainly for early stage 2 and 3 disease, we want to utilize anti-TNF drugs as a very potent drug in many of our patients, and not also forget about the lifestyle modification, pain control, emotional support issues that others have touched on. And then lastly, just to summarize, TNF inhibitors, I think we can agree to this point are the most potent medical therapies available for moderate to severe hidradenitis. We want to think about appropriate dosing of the drug and regular reassessment and troubleshooting, and that's really essential for success. It's not as though you get from terribly severe to doing well in a linear fashion. There's going to be bumps in the road, there's going to be antibody formation, there's going to be tinkering with different things, adding new things, but I think we can get there eventually. And for that reason, I really believe there's hope. I think that I start any conversation with even the most severe patient by thinking, we can make you better. I'm not sure exactly how it's all going to play out, but we're going to make you better. And I'd like to think that this is just the beginning, that as we're talking about what these, with the two main TNF inhibitors are able to do, that this is sort of like the early days of psoriasis, that in the future we'll be talking about, HISCR, of 75 or 100 as being the new norm, just like we were talking about PASI 75 and PASI 100 as the new norm in psoriasis. So hopefully there's reason for optimism. Thank you very much.